more severe, and the other way around too, where they get it severe the first time and then the second time is a milder form. I've heard about it at least.
Yeah, you know, we had a very, very sad case of a 34, 35-year-old nurse who works in our hospital, very active, not immunocompromised, was initially exposed to the virus, and within 3 days, she decompensated. She went into, you know, she was in respiratory failure, was intubated, and then she went into full-blown cardiogenic shock. And we actually had to put a VAD in her. She had a VAD in her for about, I think, like 2 weeks, and then she just died of DIC. Yeah, and she was very, very healthy. Like, you know, she was actually in the cath lab, I think, like 3 days before she initially got diagnosed with us, and it was very sad. She's very fit, not obese, no other. She has no risk factors.
Yeah.
The first cardiologist in our country, the Dr. Moin, he's a very young guy, healthy. He was perfectly okay, but he ultimately expired. We could not save him. Dr. Moin, cardiologist from Bangladesh. And even he had no comorbidity. Lots of unfortunate cases around us. But probably, maybe it is losing its virulence.
I hope so.
We all hope.
Mohsin, should we be starting?
Sir.
We should start now because so are busy. John is busy. Timir also in the cat lab.
Please
Sorry,
start.
in the early morning. We start now. Okay. Dear participants, respected faculties, especially Dr. Jon C George with us. We are grateful to you and to our favorite international faculty, Dr. Aref, Rahman, Dr. Timir Paul, also here. Also our panelists from Bangladesh, Dr. Tamzeed Ahmed, Dr. Chowdhury, Professor Mohsin Ahmed, Khandker Hssain, Dr. Habib Rahman, Dr. Fatima Begum, and my chairperson, Professor Dr. Abdul Chowdhury, sir. Before I start, I just small introduction for my today's speaker and to panelists. Dr. Jon C George is an expert in coronary vascular carotid intervention. You know, he's the director of cardiac catheter laboratory at Einstein Medical Center, Philadelphia, co-director cardiovascular research Einstein Medical Center, clinical professor of medicine, Sydney Female Medical College, student and founder Academy for Cardiovascular Collaboration, Philadelphia. He's certified from the American Board of Internal Medicine, also vascular medicine, and American Board of Venous and Lymphatic Medicine, and American Registry for Diagnostic Medical Sonography. His research is a long research profile. You see, he is the co-director of cardiovascular research 2015, adjunct research instructor 2009, director of clinical research, our research fellow, Division of Cardiovascular Medicine, research fellow, Division Cardiology, research intern, Department of Neurosurgery, research associate cardiac history. Long history. He's got lots of editorial positions. Cardiovascular Medicine 2019, and Journal of Invasive Cardiology, Cath Lab Digest, Vascular Disease Management and System Cell Studies, Journal Scans, Cardio Source, World News, American College of Cardiology, Interventional Cardiology, Cardio Source, American Cardiology, News and Views, Interventional Scientific Council, JCC, Cardiovascular Interventions, lots of positions. He's awarded lots of time. He tops Philadelphia Magazine, Dean's Scholarship, Top Docs, Best Physician, Best Challenging Case Award of TCT 2011, Mentor of the Year, Young Leadership Recognition, Who in Science and Engineering, American Top Cardiologist in the 9, Young Institute of Leadership Award, Young Award, Charles C. Carpenter Award, Postsequence Scholarship. Of course, I think everybody waiting for his talk, so I just a short biography. There's lots of awards and recognition. But we know he's a great interventional cardiologist, researcher, editor, and organizer, but he's a great human being. in AIT 2019. I get experience work with him in Bangladesh, and IPDI is the first use of digital operation device in carotid stent in Bangladesh. So he is the good doctorship in Bangladesh. Everybody is fond of him. IPDI wishes his healthy and long life. Thank you, John, being with us. We are grateful to your time with us. We are waiting for your great lecture today. Also, we have the two international faculties here. Dr. Aref is the Chief Cardiac Catheterization Lab and Director, Peripheral Vascular Disease, Medical Director, Clinical Trials Center, and Assistant Professor of Medicine, Program Interventional Cardiology, University of Pittsburgh Medical Center, and Pittsburgh Health System. Is a extraordinary interventional cardiologist, imaging, and also peripheral vascular disease. You know, we have the Dr. Timir Paul also here. Timir Paul is the Assistant Professor of Division of Cardiology, Director, Interventional Cardiology, Associate Program Director, Fellowship Director of Cardiovascular Research, William College of Medicine, East Tennessee State University. He was a brilliant student. We know everybody is a proud of Bangladeshi. Dr. Aref and Dr. Timir, welcome you in our session. Thank you, Dr. Aref. Professor Abdul, sir, please you continue the program to the chairperson.
Good afternoon, everybody. Today, our topic is intravascular ultrasound. We know that in Bangladesh, we are very much lacking in it, but we have a very eager audience to learn about it. And as the facilities are coming more and more, so our youngsters will be more conversant with the tools that we are using for imaging, intravascular ultrasound and others. And today's lecture, I think by Jon C George, will be a great step in learning process of that modality. I hope our audience will really enjoy it. And Dr. George, we are really grateful to you that you are providing us this assistance in our quest for learning. Thank you.
Thank you all. That was quite an introduction. Thank you again for having me. I'm really honored to be part of this faculty list and this esteemed panel that is here with me today to talk about this important topic. Again, I'd like to thank IPDI for this invitation. So the topic is intravascular ultrasound, and this is a very broad topic, and there's a lot to talk about from you know, the basics of how intravascular ultrasound operates, and then obviously interpretation, and then the implications of what you interpret from the image. So we'll start with the very basics. So for those that are not comfortable with IVUS imaging. So IVUS is short for intravascular ultrasound. It is not totally identical to histology, but it gives you a very good intravascular image of the pathology within arteries. So ultrasound images are produced by actually passing an electrical current through the transducer, and then it emits ultrasound waves. And these sound waves reflect off of the tissue and then gives you this image. So it's reflected at interfaces. So depending on what constitutes where the reflection comes from of different densities, it creates an image based on that reflection as it returns back to the transducer. So this will make a little bit more sense as we look at these images. So generally speaking, a white image, when the image is bright and white, it means that more of the signal, the ultrasound, is being reflected and the amplitude is greater. And a black image or a dark image means that less of the signal is being reflected. So more of it is being absorbed, less is coming back, and the amplitude is less. There are two basic types of intravascular ultrasound imaging systems. There's the rotating transducer and the phased array or electronic array system. So here are the differences of what it looks like. This is a rotating transducer where you have a wire with a short monorail, and the ultrasound tip at the point where the wire exits the rail. And that's where the ultrasounds are produced, emits, and reflected back. The phased array is slightly different, where the wire goes through the multi-element array right next to it. And again, has advantages and disadvantages based on the clinical application. So there are differences between the two systems, but you know, we'll just talk about ultrasound in general and the benefits and the resolution of intravascular ultrasound. So in normal arteries, what reflects ultrasound is primarily collagen. So the collagen that is in the tissue is about 1,000 times more reflective than muscle. So the adventitia of the coronary arteries actually have high collagen content. And so it's extremely echo-reflective. So as we look at these images, you'll see that the adventitia is what appears the brightest because of the reflection of from the collagen content. The media, on the other hand, has much lower collagen content and is mostly muscular. So that tends to be dark, and it absorbs most of that ultrasound and doesn't reflect it back. And so it's typically echolucent. And then there's the internal elastic membrane that separates the intima from the media. And that becomes important as we try to make measurements. And that's the line that you look for, the internal and the external elastic membrane. And those are important to differentiate on the images. So if you look at this picture on the top right, generally speaking, what you see on the outside of the vessel that's very reflective is the adventitia. The dark line that you see, and that can be thinner or thicker based on segments of the artery that absorbs the ultrasound and doesn't reflect it, is the media. And then what you see inside of that media, inside of that dark segment, is what the intima is, and that may be thin if it is normal, and if it is diseased, can be extremely thick, composing plaque. So those are what you look for, and here's a histology of what that same segment looks like between the adventitia and the medial muscular layer and the intima. So again, here's a normal IVUS image in a normal vessel versus a diseased vessel. And so if you look at the components of this, again, the bright segments on the outside is the adventitia. You have that thin line of the media in the middle that is dark, and then the thin intima that is normal right on the outside. And this is the lumen itself. Here's the catheter, and you see the reflection of the catheter itself. In a diseased segment, again, the adventitia remains the same, that's bright. You have the medial layer that is dark. And then within that, now you see that the intima is much thicker and is not as uniform. And now you have diseased segment of the artery with luminal compromise. So you have majority of the lumen occupied by this plaque. And so that's what plaque is. It's diseased, and the only effective lumen is what's seen here as the dark area right around the catheter itself. So looking at specific arteries, there are some subtle differences between looking at the LAD, circumflex, and RCA. You will see venous structures that are adjacent to the arteries as you do a pullback through the left anterior descending artery, and you see the anterior intercardiac vein, and then you can see pericardium. Sometimes you can see effusions. If you look at the circumflex with IVUS, you see the great cardiac vein often that courses right adjacent to it. And when you do the right coronary artery, you might see the RV vein as well. And so these venous structures become visible as well adjacent to the arteries beyond the adventitia. As far as safety is concerned in performing intravascular ultrasound for many of us that have been doing this for a long time, we know that it's an extremely safe procedure as long as it's done with the precautions in mind. And we'll get to that in just towards the end of the talk when we talk about practical procedural considerations. But this is going back several years from the early 1990s, where there were a lot of IVUS studies done to look at complications and safety of even performing IVUS. And these catheters have gotten smaller over time as well, thereby reducing the complication rates with smaller catheter systems as well. But in those days, with 2,200 IVUS studies in 28 centers in 1995, there was coronary spasm in 2.9%, and other, very rare occurrences of adverse events with some acute occlusions, embolism, dissections, arrhythmia, and thrombus. And I'll tell you, and I think most of us, most of the panelists and those that use IVUS frequently will tell you that this is a pretty rare occurrence, as long as you take the precautions necessary in anticoagulation and vasodilation before doing the procedure. Other studies, again, corroborated those findings in the late 90s, showing a complication rate of, under 1%. So, I was telling you that there needs to be some thought given to how the procedure is performed. Obviously, anticoagulation is necessary. You have a wire through the vessel. You have an IVUS catheter. The last thing you want is to form thrombus around the catheter itself. So giving vasodilators, nitroglycerin to vasodilate the capillary bed and allow adequate flow adjacent to the catheter is important. Disengage the guide so that it's not stagnant flow or dampened pressures in the coronaries while you're doing the intravascular ultrasound. And sometimes it's easy to get distracted with a long pullback in a complex vessel and get fixated on the image, but you don't realize that you're obstructing flow into the coronaries. And so you do need to be careful with that. Understanding acquisition protocols. There's a lot of nuances in IVUS imaging with improving resolution that is more advanced perhaps, but everyone has their own protocols, doing automated pullback versus manual pullback, and we'll get to that in a little bit. Identifying artifacts and finding ways around them. Labeling the vessel and recognizing, lesion location and measurements and appropriate measurements. And then, being able to look at osteal lesions, all of that takes some skill. So the motorized pullback, I think, has significant advantages in the sense that with a motorized pullback, that is where you attach the IVUS catheter to a sled that pulls the catheter back at a fixed rate, typically 0.5 millimeter per second. Or a millimeter per second, that would allow you to do measurements since it's a consistent pullback across the lesion. And that lets you to have a steady, slow pullback, avoids skipping segments and avoids artifacts most of the time, allows you to concentrate on the images without getting stuck on lesions. You can measure length and volume of the plaque, and image acquisition is more reproducible since it's consistent. The disadvantages, of course, is that you can't stay at one particular spot to study the image longer. It's consistently pulled back till it retreats into the guide, but you can always go back and look at the images or the segments that you bookmarked or segments that are of interest to the operator. Manual pullback, however, has advantages as well. It allows you to, do it at the rate that you're interested in, and you can specifically stop at regions of interest and study the image right there and go forwards and backwards to carefully assess that location. But the disadvantages are greater because it's not consistent. You can't measure length or volume because it's a manual pullback, and it's not as consistent for allowing measurements. You know, there could be more artifacts in those views as well, because you're going back and forth with these with the catheter through the lesion. So I think I don't need to tell you that there's a significant discrepancy between angiography and IVUS imaging. So as you look at these two stock images of coronaries, in the left upper, you see a left main that looks relatively free of disease, and supplying the circumflex and the LAD. And then you see on the right panel, left main that appears to have an osteal lesion right at the bend of that left main from the aortosteum. And here's IVUS images of those respective segments. And you'll see that in this case, where everything on angiography appears completely normal, IVUS images reveal that there is a significant plaque with an MLA of 4.6 millimeters squared in the left main, which is significant. So sometimes angiography in 2 dimensions will not give you the necessary answers regarding the extent of disease present. And on the other hand, in this case, where it appears to be a significant plaque at the left main ostium, on IVUS imaging, there's an MLA of 8.6 millimeters squared. There's obviously some disease here in the intima, but it's not significant, and therefore does not warrant intervention. And so your eyes can fool you in traditional fluoroscopy and angiography in 2 dimensions if you don't have intravascular imaging. And so that is exactly why the importance of IVUS imaging is stressed. So what are we looking for? And I would put this in multiple buckets. If you become an avid IVUS user, there are reasons to use IVUS imaging before an intervention, and there are reasons to use IVUS imaging during the intervention, and there are reasons for using it post-intervention. So before intervention, what are we looking for? So there is, you know, pre-qualitative assessment that we can obviously assess carefully with IVUS imaging. And so I'll tell you that, you know, on angiography, there's a variety of different findings that could suggest that we may need further imaging to quantify or qualify what you're looking at. So when you have a filling defect on angiography, or if you have a haziness and you know, luminal changes, flow changes during the injection, aneurysmal findings, ulceration, or any suggestion of dissection, then intravascular imaging will probably provide some clarity as to what is going on in that vessel that cannot be deciphered from the angiography alone. So filling defect, for example, may be a calcium nodule, or it could be thrombus. And the haziness also could be thrombus or calcified plaque. Aneurysms may just appear aneurysmal because of the takeoff of a branch at that point, and the double density causes you to think that on angiography that there's an aneurysm, but on IVUS it may be normal, but it could be a true coronary aneurysm. Ulceration and dissection sometimes could be plaque rupture or spontaneous coronary dissection. So all of these can be further identified by using intravascular imaging. So in this particular image of a right coronary artery, you see a very ugly looking lesion on angiogram. And you could argue that you could just go in, wire this lesion and fix this pretty easily and resolve the issue. But to better understand what the process is or what the pathophysiology is, IVUS imaging may be necessary. And depending on the patient's presentation, it could give you a lot of valuable information. And so in this particular case, I think it's clearly identified as a plaque rupture. And as you go through the vessel, here's the proximal segment, and you start to see a little flap there. And then as you go deeper into the vessel, you start seeing a double lumen almost like this area was a lipid-filled plaque that just ruptured, and you catch a glimpse of that further down in the artery, where you see an echolucent area along with a echodense area, and then a disease segment beyond that. And so these can help you answer some of the questions of what happened in that vessel prior to addressing it. Here is an example of coronary aneurysms that could appear both in the proximal or mid or distal vessels, and to further assess it for various reasons. One, to determine if it is a true aneurysm. Second, sometimes for sizing, to treat the lesion appropriately and make sure that there is adequate apposition of the stent in those segments. And so if you do an IVUS image through those segments, you see areas of diseased segments. This is a at the stenosis, pre-stenotic and post-stenotic aneurysm. And so you see the disease segment just proximal to the aneurysm. You get to the aneurysm and you can clearly visualize the pseudo aneurysm at that spot, where you don't have a vessel wall that's been compromised with the lumen extending out as a pseudo aneurysm. And then these channels that you see within the adventitia communicating with the true lumen. And so you can get a lot of information with the IVUS image in those settings. And then, you know, there may be normal segments, and to identify which segment of this artery that looks ectatic and aneurysmal, you may need intravascular ultrasound to specify exactly where the lesion starts, where the aneurysm begins, and where the vessel becomes normal again, to be able to treat the vessel from normal segment to normal segment. Calcified nodules in arteries are very important to identify for various reasons. As you know, treatment of calcium has been, has been known to complicate interventions and reduce patency in these vessels and increase target lesion revascularization. And so appropriately identifying the extent of calcification and modifying that if needed is critical. And so IVUS imaging provides a lot of information regarding the degree of calcification. And as mentioned earlier, calcium on IVUS appears very bright, as seen in these images. But in alternative imaging, intravascular imaging like OCT or optical coherence tomography, calcium appears dark. And so there are differences in the different kinds of intravascular imaging modalities. But for the purposes of this talk, as we focus on IVUS imaging, this is the bright calcified nodule. And what you see is just darkness beyond it. And that's because the calcium surface is extremely reflective. So the ultrasound waves don't penetrate that calcified nodule. And so you see a pitch black segment beyond that if it can't penetrate the surface of it. And so this is a very calcified nodule that extends into the lumen and compromises the lumen of the vessel. Here are some examples of haziness in the mid LAD with some, you almost see a line through this LAD segment that is bright, with some narrowing beyond, and then tapered vessel distally. And sometimes these are hard to figure out exactly what's going on. Is it a segment of diffusely diseased LAD, or is there some pathology there that needs closer identification. And what you'll see here in these images is that you have not necessarily in this distal segment, not much disease at all. It's just, you know, a bridge. So it's myocardial bridging where the LAD takes a dive into the deeper muscle layers and is compressed by the muscle. But as far as the intima is concerned, there is no plaque buildup. However, you know, proximally in this segment, there is disease. So it clarifies the segment of disease and alleviates you from stenting in areas of normal vessel where it might just be a natural taper or an intramyocardial bridge. I think spontaneous coronary dissection is another area, as I mentioned earlier, where the vessel can taper and you could have all kinds of abnormalities that are hard to look at and determine. And I'll tell you that these are cases when you have spontaneous coronary dissection that you do have to be extremely careful, as you know, in even wiring the vessel and making sure that your wire has traversed it in the true lumen, because, you know, the IVUS only tells you where the wire is. So if your wire has gone in and out of the true lumen through a dissection flap, then that's what the IVUS is going to show you. And so it allows you before stenting in these cases to be able to tell exactly where the position of your wire is, where the normal vessel is, and where you're in and out of a flap. And what you see in this image as you do a pullback is that you see those segments. You're all completely in the true lumen the entire time, but you'll see that the luminal segments change, and you see that it's compromised significantly due to a dissection flap in the vessel. Other things to think about in heavily tortuous vessels are that, and we've all been here, where you have the shepherd's crook in the RCA, where you have a significant bend or angulation in the proximal segment of the vessel. And when you wire it, it causes pseudo lesions or wrinkling of the vessel as it straightens the vessel, depending on the wire itself. So it all depends on the type of wire used and how straightened the vessel gets, but you could have significant accordioning of the vessel as it wrinkles and straightens out. And sometimes it becomes difficult to assess while you have that in place, whether those are true lesions or pseudo lesions as they appear on an angiography. And I think that's where, again, IVUS imaging can help. You know, if that needs to be clarified, tells you as you pull it back that there's no significant disease in that segment, that accordioning just appears as these artifacts in that segment. But clearly there's disease beyond it, beyond that proximal segment that needs to be addressed, and that can be addressed as needed. So the next bucket that we talked about as far as utility of IVUS is after stenting. And, you know, it's very hard to determine what is going on within the stent after a stent has been deployed with just angiography alone a lot of times. And sometimes assessing the stent edges, both at the proximal and distal end, are just as critical as looking in stent. Because that's where damage occurs as you post-dilate these stents and you have the edges of the stent dig into, you know, vessel walls and create a flap that could then be the site for restenosis at a future date, or worse yet, stent thrombosis. So this is a case of a left main bifurcation into an LAD and circ, looking at the pullback. And you see how diffusely diseased this is in that distal left main with calcified plaque. And you'll see that across these multiple runs. And when you're doing the bifurcation of the left main, you definitely always want to do a pullback from the LAD and from the circ to assess this in both views, to be able to tell exactly what's going on in each of those segments, and gives you a better picture of that distal left main, as the angle in which you pull back with the IVUS might compromise or distort the image that you're looking at. So looking at it from both the circumflex view and from the LAD view will better differentiate or define what's going on in the left main. But clearly this is a severely diseased left main bifurcation, and you see that come pulling back from both the circ and the LAD segments. And what it allows you to do post-stent, obviously you can treat it with your technique of choice with bifurcations that is beyond the scope of this talk, but it'll allow you to really look at the ostia of both vessels after it's been stented and see if you have an adequate stent area to make sure that that you've optimized the result in that anatomy, even at that bifurcation, both in the LAD ostium and in the circ ostium. And that may require further post-dilatation or further stenting based on the results that you acquire. So it gives you an ability to assess the work that you've done in the coronary, even in a complex segment such as the left main. And then stent malapposition. I'll tell you that this is the biggest fear, that you deploy a stent in a vessel and you've grossly undersized the stent, and you have no idea on an angiographic image whether the stent is opposed or not. And here in this longitudinal view on a pullback, you'll see that the stent is very well opposed here, but in this segment, you see that the stent is hanging out in the lumen, and this is going to be a nidus for a stent thrombosis. And so that is the reason why IVUS imaging, again, helps you optimize the stent that you've just deployed and post-dilated using imaging. We talked about edge dissection and the concern for leaving flaps behind at the edge. And this is an example. This is at the proximal edge of the stent, and you clearly see this flap with entrance into a lumen. This is the distal edge that looks much better. But nonetheless, these are probably stent flaps that you don't want to leave behind. And you wouldn't necessarily know that unless you performed intravascular ultrasound. So here's again, an intervention, pre-intervention, ballooning, and then post-ballooning, and then looking at IVUS images that then reveal something grossly abnormal. And what you see here is, a significant abnormality. So going from the distal vessel to the proximal vessel, right in the middle, what you see is this gross compression of the lumen. And you see the media, the beginnings of the media here, and then you see that it's being compressed. So the fact that this media is being pushed down means that it's a hematoma within the wall of the vessel that's compressing it. And so that is a big problem, and that can compromise flow, obviously, into the artery. And sometimes it's very hard to tell just looking at an angiogram whether that's just a lesion or if it is something like a hematoma, as in this case. So obviously the mechanism, there's various different mechanisms, but some of the reasons for developing hematomas such as this is because of leaving a residual flap that allows blood to enter that segment and cause the hematoma beyond or within the medial layer. And so you've treated the segment that was initially of concern in the stenosis, but then you create this little flap that allows hematoma to occur, and that could be a site that compromises the vessel. Worse yet, this is another complication that you worry about with inadequate or aggressive stent post-dilatation. and having perforations. And so, you know, perforations are much more visible on angiography, as you know, allows you to be able to see it with flow of contrast exiting the lumen of the vessel. But nonetheless, IVUS imaging will give you clarity on where those exits are. If you have the time or the luxury of being able to do an IVUS, sometimes after prolonged balloon tamponade, you're able to then quickly take in an IVUS to see the entry and exit points to make sure that you cover the necessary segments in that artery with a covered stent. And this was a very significant concern, you know, within the last decade of stent deformation. You know, our stents being compromised because as we get them thinner struts for better delivery, you're compromising the radial strength of these stents and especially the edges of these stents, and deforming the proximal edges of these stents, specifically by the guide that is deeply engaged when you're bringing the stent all the way back into the left main ostium. And IVUS imaging will allow you to be able to look at those ostial stents, especially aorto-ostial segments, where the stent may be sticking out and compromised by compression of these stent struts at the very ostial segment that have been crushed by or deformed by a guide. And so it is important to make sure that you leave behind a stent that is intact to avoid the complications of a compromised stent. And then finally, that last bucket where IVUS comes in handy is in follow-up, right? So the patient has been intervened, patient goes home, and now several months or years later, the patient's coming back with restenosis, and you have in-stent restenosis. And the first question that you ask in these patients is why, in a patient that underwent a drug-eluting stent placement, did this patient develop in-stent restenosis? And sometimes it's very hard to tell. You could post-dilate that again and put another stent in, but you end up having the same complication perhaps a few months later if it's not further assessed with intravascular ultrasound. So in 100% of cases of restenosis, I use intravascular imaging to be able to tell what the mode of restenosis was in that patient. And looking at this on IVUS with an MLA of 1.3 millimeters squared, you know that it's significant and the stent was just underexpanded. And you'll need an actual run to be able to tell what the actual size of the vessel is, but it's much bigger than the stent that was placed. A lot of different studies that have been done looking at first generation and second generation DES and the you know, restenosis rate that's beyond, you know, the focus of this talk. But, you know, there's also been a lot of studies done on the type of stent and stent deformation at the proximal edges, which have all improved based on, you know, better optimization of these stents and placement with adjunctive intravascular imaging to optimize the stent. And then obviously late stent restenosis is also further identified and studied better with imaging, allows you to again figure out the pathophysiology in these patients and figure out what needs to be done differently the next time around. And I think, you know, I'll tell you that I'll end with, I think this is one of my last slides looking at calcified in-stent restenosis. And this just shows you some of the images, differences between OCT and IVUS as well. It nicely demonstrates that in these calcified lesions, like I mentioned earlier, the calcified lesions appear bright on IVUS imaging as opposed to having this very dark background that absorbs the light in OCT imaging. So this is OCT, this is IVUS, optical coherence tomography. And here is, post-stent visualization, and you'll see the resolution differences as well between IVUS imaging that is, not as high resolution as it is OCT, where you're able to individually see each stent strut within the vessel. So there's advantages and disadvantages of both to be able to visualize. And I always end with a quote, but I will say that, and I've said this in my previous talks, the legacy of an operator is measured by the scarcity of complications. So it's important to not have a lot of complications when you're doing procedures, because that's what you're measured by. But yet the absence of complications is a measure of the scarcity of operations. So if you don't have any complications, and it's, you'll agree that you're just not doing enough cases. So with that, hopefully this is just a very good basic overview of IVUS imaging in the coronaries. And more importantly, I'm excited about having a discussion with the panel and the rest of the team here. And I'm happy to entertain any questions.
Thank you, Dr. John. Excellent presentation. I think not only fellows, your faculty also benefited from your lecture. Also, Wadud sir, please do you comment? So, Wadud.
Actually, what I like about this lecture is that George didn't hurry. He went through every scenario, just show simple examples how this scenario plays out in IVUS and how can we actually differentiate one from the other. Thank you, George, for a very nice, simplified, but very beautiful, illustrative lecture.
Thank you. Dr. Aref? Dr. Aref Rahman?
Yes.
Yeah.
So first of all, thank you, John. It was a great overview. And, something that I'd like to share with all the faculty members here is that, so I tend to use a lot of imaging, whether it is IVUS or OCT. I tend to use a lot of imaging, but I do want to, make one thing very clear to everybody is that whenever you see a lesion, especially if you're going to follow guidelines, they say that you want to use FFR to determine, or IFR or RFR to determine the hemodynamic significance of a lesion. We do not tend to use IVUS or OCT to determine whether a lesion is significant or not, unless of course it's left main and you're trying to determine the area. But if you have any borderline or moderate disease, if you want to use any borderline disease, you want to use something like IFR or RFR, determine the hemodynamic significance, and then I tend to use OCT or IVUS for stent sizing. Because I think stent sizing is very important, pre and post procedural. We want to make sure the stent is adequately apposed. There's no malapposition. You don't have any edge dissection, and you actually get a true stent size play. So I think that's, one thing that we need to understand whenever we use imaging for our modality.
Thank you. Thank you, Dr. Aref. Dr. Timir Paul. Dr. Timir.
John, great presentation. Thanks for your time here. I have to leave, but I have one question following Dr. Rahman, that hemodynamically significant, we do IFR and FFR for sure most of the time. I think we use most of the cases, but in some scenarios, you also can use the IVUS for hemodynamic significance, like you showed that left main disease, if it's minimal luminal area less than 6, like 5.9, that most likely hemodynamically significant if you use one modality instead of two to save some time and money. And it correlates with FFR 0.8 or less. And also for, I think that LAD disease, if its minimal luminal area is 4, less than 4, then you can use that criteria as a hemodynamic significance. I mean, there is multiple data and there is some discrepancy, but that's kind of standard. Is that right, John?
Yeah, so those are, across huge population sets. So I think the data for the minimal luminal area of 4 millimeters squared, we extrapolate that from proximal LAD studies across the board. And so, we tend to use those numbers. The problem is that people extrapolate that and then tend to use it in other segments. And then it's hard to know whether that is truly applicable to that particular patient. So if you're using that same cutoff in a mid RCA, I don't know. whether that is significant or not. You know, but nonetheless, you're right. There have been studies that correlated IVUS MLA findings to FFR, but the problem is that those are in specific subsets of patients. And the same with left main. You know, for me personally, IVUS imaging helps me identify the degree of disease state, but physiologically it becomes difficult because I've seen left mains as large as 6 millimeter, and I've seen left mains as small as 3 millimeters. And so, you know, when you have such discrepancy in sizes of left mains between patients, it's very hard to settle on a minimal luminal area that can be used across the board as a cutoff for significance of a lesion. And so, yeah, I agree. There is data on there that you need to use with some caution, but I'd rather use it as an adjunctive modality to facilitate our stenting and optimize the stenting as opposed to determining whether the patient needed a stent.
Thank you.
Correct. I agree. And also I want to add that, you know, with John's presentation, that please keep in mind that one of the reasons why we do imaging is because we want to prep the vessel well. As John mentioned, that if you see extensive calcification, you know, no matter how much you just try to do plain old balloon angioplasty or stenting, you're going to get malapposition. And if you see the burden of calcium, then you want to consider using something like atherectomy or even a scoring or cutting balloon. I'm not sure what you have in Bangladesh, but you know, the main purpose of imaging is to understand not only the vessel size, but how to prep the vessel, because our ultimate goal is to minimize restenosis.
Thank you. We are happy Dr. Professor Afzalur sir with us. He is the main person who is the more popular IVUS in Bangladesh, because he bought IVUS in government hospital. So it is a more cheap rate to get to the IVUS. So juniors and fellows are working more IVUS, left main disease, bifurcation. Professor Afzalur sir, please give a comment.
Okay, thank you very much. And this is a great talk. My friend John, and I'm seeing the Aref and Timir also. I'm seeing the Timir. How are you? Everybody's fine, I think so. It is nice to see you in the webinar. And suppose all of the people will join the BIT program in the February. I'm thinking, I'm looking for that. So thing is that the imaging has a lot of importance actually. We can say that this is a very expensive, but what we have learned from our experience that IVUS catheter can be used. In a experience in IVUS catheter, I'm sure in US you are not using, but in ICPD we are using 3 to 4 times. So we can use it. And if you use it very gently, and if the lesion is not very dirty, then I am sure that you can use it. But we should not do it. That's a different issue. So definitely, John illustrated very nicely in the different subset of the patient. That is very important subset that we have to do it. If the type A lesion, we can go ahead angioplasty, plain angioplasty, but other than we have to do it, no doubt about that. And regarding the atherectomy devices, only we have a limited access to the rota. We have no other devices. Only we have a rota, maybe in the 2 center we have the rota, but the number of the rota is very less. Now I'm looking for the, actually, I am very fond of that is lithotripsy and also the OPNC balloon. That 2 products will be available very soon in Bangladesh. I think so that will help for our people, for our doctors. Because rota, you need a very good training. You need enough numbers. But for OPMC balloon or lithotripsy, learning curve is very short. So that is very important in Bangladesh. In rota, very difficult. Atherectomy, other devices, may be difficult. But definitely we should have, and in making institution we have. So thank you, Dr. John. Thank you. It is nice to see you again. I love to see you because I said that John is the BIT innovation. You know what is that? John and Sanjay is the BIT innovation.
Thank you.
Thank you very much.
Dr. Tamzeed, do you hear me?
Yes, thank you. It's an excellent presentation by Dr. John. Let's congratulate him. And of course, I'd like to say a comment from our Professor, Afzal sir, and also from Dr. Aref. Basically, in our circumstances, as you can There's no question of compromise in this issue of not doing IVUS. But in our situation in Bangladesh, we sometimes avoid cases doing IVUS. But we choose patients to save money or save time, whatever. So sometimes we choose patients, particularly for left main patients, bifurcation patients, or CTOs, where we have to analyze the lesions better. So we use IVUS. And obviously, we consider IVUS as an anatomical tool, whereas FFR or IFR is a physiological tool to assess the lesion. So sometimes we don't know how to compare them both, but actually it is more supplemental than actually we can compare these tools with each other. Thank you.
Thank you, Professor Dr. Khandker Shahid.
Thank you, Mohsin.
Yeah.
Thank you, Mohsin. Thank you, Dr. John, for nice presentation. IVUS is a nice modality for optimization of the PCI, especially lesion preparation and assessment of the pre-intervention assessment of the lesion, whether there is chance of slow flow or distal embolization, or whether we need pre-dilatation or not, or we need extensive dilatation with NC balloon if there is calcification. This is nice. But the question is, what should be the stent size? What's the relation of the size of the stent in relation to the plaque burden and area stenosis and the length of the vessel? If there is plaque burden 90%, if there is plaque burden 70%, is there any difference in the size of the stent? The vessel size is same. The both vessel 4 millimeter external elastic lamina to external elastic lamina. One vessel containing plaque burden, that is 95%. And another vessel, the same size vessel, but there is plaque burden is around 60% or 70%. Both the stent size should be same or not. If there is extensive calcification, what is the effect of stent sizing? Whether this stent should be compressed or not. How I can, in this situation, how I can size my stent, actual size. This is my query to Dr. John. Thank you.
John, yeah.
Yeah, so that's a great question. And what's important to recognize is that the stent sizing is not based on the plaque burden, but on the vessel size itself. So the sizing of the vessel, I mean, we could talk about this for a long period, but sizing of vessels can get tricky, especially if the vessel tapers. So you want to look at the actual size of the vessel distal to the plaque, and you want to look at the size of the vessel proximal to the plaque. And have some sort of an average size that you can use to optimize that segment of the vessel. So whether it's 95% stenosis from the plaque or 70% stenosis from the plaque, the stent is sized based on the reference vessel size, which is without the plaque. So I hope that answers your question. And that's when it gets tricky, when it's calcified or resistant or fibrotic plaque that does not expand. And that's the reason why you need to use sometimes other modalities to be able to crack that plaque and allow it to expand to the actual reference vessel size. So you may require you to use other tools in that in a calcified 70% stenosis segment that you may not even have to use in a soft 95% stenotic lesion. So I think there is some skill there that needs to be addressed. As far as patency in these segments, there's multiple studies that have looked at the minimal stent area after stenting. And so if you can get an MSA of 90% after stenting, then you're safe. We know that the outcomes are fantastic. So even if you don't get full expansion, if you can get up to 90% of the minimal stent area in those segments where they're resistant, then that lesion will probably do fine. Aref, you have any additional thoughts on that?
No, I think that
I totally agree with you, John.
Okay, Dr. Aref, please add something.
No, I totally agree with John that's exactly what I do. Like, whenever I image a vessel and I see plaque burden, I think that changes my practice at that point because I know I'm not going to be able to crack it. I'll try it using a regular balloon or a non-compliant balloon or a cutting balloon. And when I'm unsuccessful in cracking it, which is in most of the case, then I'll end up using an atherectomy device. And then I use the reference vessel, as he mentioned, proximally and distally. So we don't end up over or undersizing it, try to go in between, and then we end up post-dilating maybe the proximal part a little bit better to achieve the reference vessel size.
Thank you. Professor Afzalur, sir, do you add something?
Yes. I think so. That is very excellent comment. I totally agree with the John. But thing is that if we select the size of the stent, we have to take the distal reference vessel diameter, not the proximal. That's, will you agree with me? That is the distal reference vessel diameter. Suppose if the distal vessel diameter is 2.5, proximal is 3, then we have taken the stent is 2.5, not in between. That's better. That is distal. That decreases the chance of distal dissection. And other thing is that what John told, that 90%, that is MLD is most important independent predictor for restenosis or stent thrombosis. So if the MLD is more than 90%, then you should be happy, very happy about that. And you get the calcified lesion. Usually I don't like use the cutting balloon. I love to use the scoring balloon and NC balloon, but rarely I use the non-compliant balloon. Because yes, you can see that if the non-compliant balloons expand properly, then you can say that the calcium is not very hard. But rarely I use the, in the calcified lesion, rarely I use the non-compliant balloon. I use the semi-compliant balloon. I use the non-compliant balloon and the scoring balloon. Definitely cutting balloon has good role. But I think so what Aref, if we decided that you need a rota, after IVUS, because your IVUS, you are seeing the IVUS. If the calcium is superficial, it is more than 270 degree, then why you will dilate the lesion with the scoring and cutting balloon, then next go for the rota, or rather start from the rota?
So because you always want to prep it a little bit. So the way I do it is that whenever I see a lesion that I know I'm going to use a rota or a CSI, I will dilate a little bit just to kind of create the pathway so that I don't have any resistance in getting the rota, the burr down, or getting the CSI device down. So I don't dilate it to get the original size, but more just to create a pathway so that I don't have any resistance or any problem in getting the rota burr down.
But some study shows that if you predilate the lesion, there is chance of the dissection or proportion is more in the rota.
Sure, no. So if I'm going to commit to using, say, a rotablator or a CSI, then I won't dilate it to get the maximum size. So what I do is I won't use a non-compliant or even a scoring balloon. I'll just use a small compliant balloon just to make sure that my rota burr can actually go through, because there's lots of times where I've experienced that, there's so much calcium burden there that I'm unable to actually get the rota burr down there.
So that rota is only to make the room.
Exactly.
Make the room.
So the pre-dilation I just use a regular compliant balloon, nothing very aggressive. And if I'm going to commit to CSI or
Dr. Kaisar Nasrullah.
Yeah. Assalamu alaikum and good evening to all. I would like to appreciate the IPDI and the Professor Wadud and Mohsin for organizing such a wonderful webinar. And also thanks to John and Aref for your beautiful lecture and comments. Learned a lot from all of you. Thank you all. About calcified lesion, yes, you have to know your vessel well, whether it can be doable with, scoring balloon or whatever, cutting balloon, OP balloon, which is not still available. Before doing that, you have to do ideally an imaging by IVUS is good, or OCT. And in IVUS, there are some criteria like superficial nodule and superficial calcium, which is thick. It is called 500 micron or more, and the arc is covering the vessel lumen more than 270 degree. Then you have to go right away with some of the atherectomy device. And before putting any stent, you have to be sure that your vessel is well prepped and it can accommodate the stent very well. So after doing the atherectomy, whatever you have done, either with balloon or rota or whatever you're comfortable with, you have to do again imaging. And in imaging, if you see there are two fractures perpendicular, then you will understand that. Then if you put a stent, it will achieve your minimal luminal diameter. And in IVUS, you will see that there are some signs of effective rotablation, like two fractures perpendicular. Second is reverberation. You can see reverberation in IVUS, which will allow you to understand that yes, now the lesion has been prepped well. Now you can do a non-compliant balloon dilation and then put your stent. But before preparing the lesion, never put a stent, because when you put the stent, you are done. Then you can't expand it. And sometimes what happens when you try to over dilate it with a post-dilated balloon, then it expands on the opposite side of the calcium, and it might perforate if it is in the pericardal side. If it is myocardal side, you can get away with it, but if it is pericardal side, it can rupture. So careful while doing the calcified lesion. And about the question of Shahid Bhai, I would like to add that yes, minimal luminal diameter, you can average proximal or distal luminal area of a normal reference diameter, or you can take the distal luminal diameter of a normal vessel and choose your stent size. And when you have achieved 90% of your minimal luminal diameter, or sometimes it will say that 50% of the plaque burden has been reduced, then you can say that yes, you stent is well expanded, and it will bring good long-term effect as well. Thanks.
Thank you. We move to the next one cases. Dr. Farhan Ahmed with us. He's assistant professor of NICPD. He will present the case. Then after go to the discussion. Dr. Jan, okay, move to the presentation. Dr. John. Okay, Dr. Farhan. Okay. Farhana, please share your screen. Farhana, please unmute. No sound, Farhana.
Am I audible now?
No, sound is very low. Please volume, please high.
Is audible now?
You're audible, but not so much clear.
Is it clear now?
Okay, you start.
Okay, thank you. First of all, I'd like to give thanks and congratulate to Dr. George for his brilliant presentation, and the respected chairperson, moderator, esteemed panelists from home and abroad. Very good evening. Actually, IVUS is nowadays very essential part of the procedure, and it makes the life of operator in capital is very easier. Today, I'm going to present IVUS
The sound is very low, Farhana. Please volume.
Yeah, I'm trying. Am I audible now? Is it
Yeah.
clear now?
Yeah.
Okay, thank you. Today, I'm going to present IVUS guided PCI, and I plotted here 3 different cases to demonstrate how IVUS is helpful in different situations. My first case is how to evaluate a diffuse disease. All we know the diffuse disease poses a unique set of challenges that can be addressed by using IVUS. Let's see how we tackle the disease. This is an angiogram of a 48 years old lady, presented with recurrent chest pain for 1 week, and patient had Kaisar for 1 year. She is diabetic and hypertensive. And from angiogram, we appreciate that there is 70% stenosis in the medial segment of left main, and the left main and LED is diffusely diseased or narrow caliber vessel. We cannot surely determine from angiogram. And there is a minor plaque in LCX, and RCA is free of disease. So it is very difficult to appreciate angiographically. Already George described about that, whether it is narrow caliber or it is diffusely diseased. So we decided to go for IVUS, and IVUS shows that. And from IVUS, we see that the left main is significantly diseased with plaque burden 61%, and angiographically the left main is nearly beyond 2.5, but it is much higher in diameter, was revealed in IVUS. And LED found to have diffuse disease extending proximal to middle. And from the IVUS, we also delineate that what is the what is the size of the stent in this case, what would be the distal landing zone, proper distal landing zone, as we want to put the distal part of the stent in a place where the plaque burden is less than 50%. And we also appreciate that there is a lesion in the left main that extending near to the ostium. So we decided to put our stent covering the left main ostium also. So we pedalate the lesion with 2.12 millimeter balloon, and we took, as the distal diameter of the vessel is 2.5, so we select the stent with 2.5 millimeter diameter and 32 millimeter length, and deployed it, and took multiple views so that we should not miss the left main ostium, to ensure the left main ostium is properly covered, and is deployed at 2018. And IVUS after stent deployment, we see that there is malapplication of the stent in left main and also in the distal LED. So we again dilate the lesion LED with 3 into 10 millimeter vessel balloon at 20 ATM, and we popped in left main with 3.5 millimeter balloon, 3.5 into 8 millimeter balloon at 16 ATM. So you must appreciate there is a well deployment of the stent in the left main and LED. And second case is tackling the trifurcated calcified left main lesion. It's a 60 years male having dyslipidemia and hypertension, presented with the symptom of chest pain and minimal exertion, and we have the anti-organ motion abnormality distribution of 59%. And the angiogram reveals there is a trifurcated lesion involving the distal left main, proximal LED, ramus intermedius, and there is also minimal plaque in the LCX. And you also appreciate there is a ring-like calcification in the proximal part of LED. And this calcium is also visible in fluoroscopy. And RCA is having a plaque. So what would be the actual statistics in this situation? Find out that, and to get the proper anatomy and extension of the calcification, it is actually nearly possible most of the time by only coronary angiogram. So we need to do IVUS. As the coronary angiogram, the calcium and the proper anatomy sometimes underappreciated. So we go for IVUS study of these cases. And you see there is calcium arc that is less than 80%, and there is a mixed distribution of calcium. Some are in the near the lumen and some are away from the lumen. So in this case, we first prepared the lesion bed by semi-compliant balloon, then cutting balloon, and subsequently by NC balloon, and took a stent 3 into 48 millimeter and deployed it, crossing the, this also we covered the left main ostium and post-lated the lesion with NC balloon 4 into 12 millimeter. And this is the final IVUS after the procedure. There is attaining expected luminal diameter, and the stent is well deployed in the vessel. And this is the final angiographic view with a good result, angiographic result. This is the follow-up CT angiogram having good patent vessel. And my third case is IVUS is helpful in a situation where we cannot do PCI with using much contrast. And in some situation where there is a chance of contrast-induced nephropathy, or there is a chance of worsening of chronic kidney disease. Here is such a case. Is a 55-year-old gentleman presented with the complaints of ongoing compressive chest pain. Patient had a history of chronic stable angina for last 1 year. Patient was smoker, hypertensive, and having stage 4 chronic kidney disease. His GFR is 20 ml per minute. So we did initially ultra low contrast angiogram with proper pre and post hydration of the patient. And you appreciate from the angiogram, there is a significant lesion in the mid LAD. And RCA is almost disease free. After proper discussion with patient, we decided to go for, as the lesion seems to be very simple, we decided to go for zero contrast angioplasty after 7 days of baseline angiogram. So we took the previous angiographic film, are uploaded to the monitor as a guide for coronary wearing. EVU guide catheter was engaged to left main ostium, and 2 wire, 3 wire, 1 wire is in the LAD, 1 in LCX, and 1 is in diagonal is negotiated. But when we did IVUS, what revealed? Let's see. There is a lesion, significant plaque burden in the LAD ostium also. So a apparently simple case turned into a complex one. This is the LAD ostium. And the left main have devoid of significant disease. So what should we do now? What would be our strategy now? As the left main is devoid of disease and ostium is significantly diseased, so we decided to keep the stent, put the stent covering the only LAD ostium. But you know, it is very difficult in zero contrast proper placement of precisely placement of a stent in LAD ostium. So first of all, we put a stent covering the middle part of the LAD. And at this point of our intervention, what we did, LCX were pulled back, and the middle portion and marker portion of the PCI wire in LCX kept in the left main to LCX to make a metallic silhouette for precise LAD ostial placement. This is the marker wire, and this is the place. Angiographically, we think that this is the place where the ostium is located, and with a minor 1 millimeter dye, we also prove it angiographically. And finally, we deploy the stent just precisely in the LAD ostium. post-dilatation.
Thank you, Farna. Brilliant case. Brilliant case.
IVUS is useful tool to understand the nature of lesion and optimization of PCI. Diffusely diseased LAD and left main should undergo with the guidance of IVUS. Proper planning to deal with calcified lesion is not possible without IVUS. And to perform zero contrast PCI, significant expertise in IVUS is mandatory. Thank you so much for your patience hearing. Thank you.
Thank you. Thank you for a brilliant case. Thank you. Dr. Aref? Dr. Aref, you see the case? Please unmute yourself. Unmute.
Oh,
yeah.
Okay, sorry. Yeah, so excuse me, excellent cases. You know, great to see that IVUS is being done and used in Bangladesh. I know last time I was there after BIT, I actually worked with Dr. Pradeep at NICBD, and we did about 7 or 8 cases of IVUS there. So, you know, it's great. And I love the fact that you're using it for zero contrast as well. I remember reading an article by Dr. Afzal that you were one of the first ones to do it in Bangladesh with zero contrast intravascular imaging PCI. So, you know, it's great. One thing I like to, you know, tell all my fellows here who I train is that the more you get comfortable in using it, the more better you get at it. Same thing as angioplasty, right? The more you do it, the more you get better at it. And the more you do IVUS, or the more you start seeing images, attend workshops, you'll understand what you're looking at in the vessel and how to treat the vessel. And you become what we call an expert operator. So, you know, I would encourage you all to use it whenever feasible. And, you know, I know cost is a big issue in Bangladesh, but at least it's great to see that it's available in the government hospitals. And I wish you the best of luck.
Thank you, Aref. Being long time with us. Thank you, Aref. Professor Abdul, sir?
Yes.
Abdul, yeah.
Yes, now, thank you. Now everybody is doing the IVUS. That's good. And IVUS also expanding the private sector, hopefully till more and more. I think so. The last case, what Farhana illustrated that is this technique was, I think so, that is published in a journal, no?
It is.
It is claimed that this is the first case report in the world, actually, by taking the marker wire across the LAD stent, I think so. They accepted and they published it. So this is a really great case, I think so. And but we are facing a lot of the trouble. In the private sector, we are facing more problem than the government sector. I will say that in the government sector, it is very easier to work, but in the private sector, it's more difficult to work. That what I understand that, because in my tenure, in the government sector, it is more easy to organize because fund is there, and patient does not look after that. But in the private sector, it is very difficult sometimes. That's why the penetration of the IVUS is less. That's right.
And also, you know, there is a time involvement. I know, because I remember when I worked with Dr. Pradeep, when I was in Bangladesh, he had 14 cases he had to do. And I know time is also a factor, right? And, you know, to do the IVUS, it takes time. You have to evaluate the image. We have to incorporate that as well. So I completely understand the limitations.
But I think so. There is a big many number of the cath lab in the NICBD. It shouldn't be a problem. I think so. IVUS will become popular in Bangladesh.
What about OCT?
Oh, OCT is only one center is doing that. Only one center is doing that. But their number is not so big, so many. Few cases. I don't know about that number. But OCT, I think so less penetration because OCT is more expensive than IVUS. I would say that. And OCT catheter usable. I don't know OCT catheter can be used or not. I am not sure. But IVUS catheter can be used. That's important. IVUS catheter, you can use that. Yeah, and Boston Scientific IVUS catheter is fantastic. I like that one. Maybe other companies also good, but Boston one I like that.
Chowdhury, sir, do you hear me, sir? Yeah.
Yes, I can hear you. I'm not an interventionist, so I cannot make much comment about that.
You also interventionist, sir.
Little interventionist.
But Bangabandhu, I think not so IVUS or OCT Bangabandhu.
We do not have the IVUS or OCT at BSMMU. The lecture on basic IVUS was fascinating. And as a matter of fact, it's for the first time I'm through some lecture. And probably I have learned all the basic. So I want to convey my thanks to Jon. And one issue that I wanted to mention about the cost and the IVUS. It is very often it is said that the IVUS is costly. But in our old days, there was a notion that if you want to buy the quality costs, but anything less than quality may cost more. So should be in terms of intervention, especially if it is calcified lesion and other complicated lesion, which has got much more chances of restenosis. You need to revascularize again that segment. So this thing has to be kept in the mind. If it is needed, then probably it will not be costly, because subsequently the cost might have been more than what is apparent at this present time. Thank you very much.
And I agree. There's been lots of studies that have actually showed that although there may be a small upfront cost with using the IVUS catheter or an imaging catheter, if you look at the long-term data in terms of restenosis rates and reduces the risk of dissection and all that, you're actually saving money in the long run. So yes, you're right. There may be a little bit of upfront cost, but in the long run, you're actually saving money. And as Dr. Ahmed said, it's the quality. It's not the financial aspect of it.
Dr.
Mohsin, if there is a chance to talk.
Yes, Dr.
Dr. Yes. I must congratulate the IPDI to arrange such a wonderful program, and the Dr. Jon, who has presented the IVUS very interestingly and deliberately. I have some question to the Mr. Jon, and I have some recommendation. I also thank to the Dr. Aref, who worked last year with me and who did a lot of IVUS. And I also thankful to the Dr. Afzal sir, who introduced IVUS in NICBD. Now we can do only, in a case, we can do IVUS only $250. For this reason, in my unit, in every PCI is optimized by IVUS. In the last 1 year, in my unit, we did the 170 IVUS. So the number, already said, the quality is the main. Initially, in pre-IVUS era, we usually do 10 to 15 case PCI per day, but now with IVUS, nearly 8 to 10 case, but the quality matters. Dr. Jon, I have some query to you. There is a, the for...
Jon is here?
Jon is in the catch.
No, he just
left. Dr. Arif
No, I'm sure Jon is living because he is very busy guy.
Yeah, Dr. Jon is the
Okay, Dr. Aref.
Yes.
Dr. Aref, do you have the artifact, to expertise in IVUS, we have to know about the artifact. The most common artifact is the bubble, but do you have any experience or how frequent you are getting the nod, the near VU artifact, ring down artifact, side lobe, this artifact, how much you are going and through the, or we are missing, sometimes we are missing, but still we are in the primitive phase of the IVUS in Bangladesh. We're trying to learn this subject. And another thing I want to know about how much percentage of cases you get the positive and negative remodeling cases. And do you routinely do the IVUS after balloon dilatation? Usually we do the pre-balloon and after the standing. But some Japanese recommend they do the IVUS even after the balloon dilatation. What is your respect?
So, so in terms of the artifact, I think the more you get used to it, the more you do it, the more less likely you'll see the artifact because you get more comfortable with the procedure itself. But in terms of the number of cases where I have artifact and restenosis, I actually don't have those numbers, but maybe I can try to look it up and I can try to share it with you.
Yes.
The other question you mentioned about doing ballooning. So that's exactly what we actually do in our hospital. So, in our hospital, I've created a protocol where, like I said, if it's a left main disease, then we end up using IVUS. But if it's like a mid-LAD lesion or a RCA disease, if it's not distal, I will always use an FFR. If it's moderate disease, then I will balloon it, and then I will use IVUS or OCT for stent sizing, and to make sure that I've actually, optimized the vessel for stenting. Now, if I have a case where I'm unable to deliver the IVUS or OCT, then I will still try to use something like a balloon angioplasty and then just proceed with it. But I do end up using imaging after balloon dilation, even sometimes pre-dilation as well.
Yes, and my last question is, think there is a relation in the distal left main and proximal LAD. So there is a gross mismatch between the sizes. I think the proximal LAD is 3.5 and the left main is 5. So what is your plan? It is the 5 millimeter in the left main. So if you so we have to take the stent 3.5. So how you will post dilate the 5 millimeter in left main?
And that's what we talked about earlier on, and I think John alluded to this. We end up taking the average in the United States. I know the guidelines say we're supposed to look at the distal normal vessel and try to use that, but you're right. If you're using, especially going to left main into LAD, you have a 5 and a 3.5. A 3.5 Zion stent will not go beyond 4.5, right?
Yeah.
So that's the reason why what we do is that we start off with like an average where we go with a 4, but we don't deploy it to the optimal level. We'll probably deploy it to maybe about 10 ATs and not to the 12 ATs, so we don't get the full dilation in the distal end. And then the proximal part will dilate to a 5, and then we'll re-image again just to make sure there is no edge dissection. Because you're right, whenever you're choosing a medium-sized stent or an in-between stent, there is a risk of edge dissection. That is why we'll re-image again just to make sure we have not caused any distal dissection.
Okay.
And that's the reason why John alluded of taking the average, because that's what we end up using a lot. We end up using the average. Although, like I said, the guidelines as mentioned by Dr. Afzal and Dr. Wadud Chowdhury is that you should follow the distal thing, but
distal reference segment,
there is significant mismatch.
Thank you.
Okay. Thank you very much.
Thank you. Hope to see you soon.
See you soon.
First, I'd like to my gratitude to international speaker Jon and Aref, also discussing now. Last year I talked with him in Prodip Katlan in the control room. I think he can recognize me. But learned panelist, I also visit Tennessee and his home. And also IPDI, the chairperson is Professor Wadud. And Professor Mohsin. I like to say that in NSCBD, we are dealing with the IVUS and we are also imposed to the thesis for our postgraduate cardiology student. Also involved, Dr. Prodip is involved in the COVID, and also we are trying to be guided, IVUS guided PCI in incorporating the final part of the thesis of a cardiology student, postgraduate resident student. And I like to ask one question. I asked a lot of questions in that time. I think I can recall. I asked a lot of questions. I like to one question, very silly. It may be very silly or it may be very informal. Considering the very poor people, when we deal very poor people, severe left main or non-critical LAD, non-critical clean lesion like 70 to 80% left main osteoproximal. If we routinely do post-dilation with NC balloon or OPM balloon, can we substitute the IVUS?
So, it's a very good question.
You understand?
Yeah, I completely understand your question. So it's very interesting that only 30% of the people in the United States use intravascular imaging. And why is it only 30%? Because 70% of the people actually believe that if you do a good post-dilation and you have enough experience, why do we need to use IVUS? So to answer your question, can you substitute it? I mean, people are doing it, but if you actually go back and look at some of the data that has been presented, they actually show that, our eye is we end up undermining the stent size a lot whenever we just use the visual aspect of an angiography. So yes, do we get away with it? Sure, we get away with it. If you end up post-dilating pretty aggressively and it looks like you have a good step up and a step down, yes, you should be fine. And there are a lot of cases when it's an emergency, I don't have time, we will just end up doing balloon angioplasty post-dilating. But if you have the time and you want to get good quality of work, as mentioned, I think we should try to use imaging. But yes, you can get away with it, as long as you post-dilate aggressively.
Thank you. Dr. Khandker, any question? Dr. Khandker, any comment about him?
Yes. Hello?
Yes.
Yes. aggressive post-dilatation. Regarding this, I have some comment. Tissue protrusion. Tissue protrusion and the aggressive post-stenting dilatation. Is there any relation? If there is relationship between the tissue protrusion and the dilatation pressure, so what is the optimum pressure? What should be the optimum pressure? Is it every time the high dilatation has high pressure post dilatation is beneficial?
No, no, it's not. It's not. I think what you need to do is that you need to, if you're not going to use any kind of intravascular imaging, then you need to look at the actual angiography and make sure the stent is, you know, pretty well opposed angiographically, meaning you have a little bit of a step up and a step down. That's good enough. So if you put a 3.0 stent and you're going to post dilate with a 3.5, if you go up to 12 ATs, that's good enough, in my opinion. You don't have to take it up to 16, 17, or 18 ATs. You know, it's all about just getting the stent to be sitting well against the wall, and angiographically, it looks like that the stent is equal to the, you know, the normal or the distal normal size of the vessel. And in terms of any correlation between tissue protrusion and any outcomes of that, I really don't know of any data behind it. There may be, but I'm not aware of it.
Can I add something?
Yeah, well,
actually, tissue protrusion is important when we are doing acute cases. In acute STEMI, you better not do post-dilating, because in that case, tissue protrusion and the resultant equidistant thrombosis and every other complication is much, much more
higher. Right, correct.
Yes, correct. Exactly, right. Was it Dr. Tamzeed Ahmed?
Yes, thank you very much. Very excellent discussion. Actually, can I ask some questions to Dr. Farhana about her cases? Dr. Farhana, are you ready for that?
Yeah.
Do you hear me? You have shown 3 cases, excellent cases, of course, all of them. About the second case, you have done the IVUS on the LAD. But did you run the IVUS from ramus intermedius? It seems to be quite pinched artery. Osteum of the ramus was quite pinched, disease there. It was a good size of ramus as well. Did you do any IVUS or FFR to assess the post-stenting condition of that artery?
Farhana, you have to unmute.
Please. Okay. Did you get my question? I mean, did you check the ramus artery after stenting the LAD, left ventricle LAD?
No, did you check the ramus artery, long ramus? Yeah.
Angiographically, it was okay. Like before stenting, it is as if before it was before stenting. So we didn't check it during after.
Since you are doing an IVUS, you can run the ramus as well.
Most of the trials say that this is not in the plaque burden. This that only for the, I think, vessel.
Mohsin, let me clarify that.
Yes.
The IVUS was done in the LAD and also in the LCX, not in the OM.
In the
ramus. Our plan is that to do not to do stent, because if we put the stent, because ramus was a good run-up. It is that is good run-up was there, and there is a plaque actually there. So we try to peridilate dilatation. The lesion is significant, no doubt about that. We have to peridilate dilatation. We put a stent, and the flow was fine. So, and we have confirmed it. That's why we unnecessarily don't like to do any IVUS on the OM. It doesn't require. I'm not sure required. That is proven by the follow-up CT angiogram. You can see that on CT angiogram, the ramus intermediate was patent. So, and our plan is not to put a twist stent, because if you put a twist stent, then one is the LCX, one is the LAD. So you will be big trouble. So why you will do that? That's why. This is philosophically we have not done this actually.
Okay.
Most of the trials showed that it is the carina shift, not in the plaque shift. Most of the trial, all the study shows, usually it's the carina shift, not in the plaque. But so Kaisar, Nasrullah Khan, do you comment? Last comment from you. The long time, 2 hours we are going on.
Yeah. It is the second webinar, and we do third webinar for Professor Chowdhury, BCIC.
Yes.
So my wife has threatened me to leave me very soon. If I pass so much time in the webinar in the holidays.
Yeah.
Anyway, and taking this question, what I wanted to say that yes, sometimes the branches are thin, like ramus diagonal, which seems angiographically significant, but if there is a TIMI3 flow, don't worry. this is simple caniner shape, not plaque shape. But if you're in doubt, then you can do an FFR, and if it is significant, you can dilate it or stent it, otherwise not. But 99% case, I can assure you, if there's a TB3 flow, don't worry. It doesn't matter.
Thanks.
Exactly. And if you look at that FFR guidelines, as Dr. Kaisar mentioned, that is exactly correct. If you have a side branch and you have more than 70% flow in there, leave it alone. If you are suspicious, then do the FFR as he said. But most of the time you have enough flow, you don't have to do anything. That's exactly correct, right? I have to go into my cases on the table. It's nearly 9 o'clock.
Thank you, Dr. Aref.
Okay.
Thank you so much for your long time with us. Thank you.
Dr. Kaisar, I'm going to call you. You are stenting one of my cousins tomorrow. I'm going to call you.
Thank you, Dr. Aref. Thank you.
Okay, take care. Assalamu alaikum, everybody. Assalamu alaikum.
Okay, Dr. Professor Abdul, please conclude the session.
I was mesmerized by the presentation as well as by the intelligent discussion that we have had today. And very important question, including what we should do in our context, that has been discussed. I think the whole thing will be very beneficial for the fellows who are interested in doing the imaging and who are trying to be a very good interventionist. Their generation should be much better than us. They have the much more opportunity, and they should try to make the most out of it. Knowledge is so important, and the skill you should acquire by doing it again and again. But having the beforehand the proper knowledge of how to do it, what to look for, when to do it, and what are the complications that you need to avoid, what are the precautions that you should take, and how to bail out of a dangerous situation. All these things you should prepare yourself. And vascular imaging, of course, will help you to achieve a much better coronary revascularization, and that you should be doing much better than us, I hope. And thank you, the panelists. Thank you. Dr. George is not here, but I would really like to thank him. He's given a very beautiful lecture. And also, thank you, Beximco Pharma, for being with us. And Farhana, that was nice, the presentation. Mohsin,
thank you, everybody. Thank you.
Thank you all.
John, he's busy in the cath lab. Dr. Aref, Dr. Timir, and also all the panelists. Thank you, everybody.
Thank you.
Allah Hafiz. Thank you. Assalamu alaikum.
And thanks, Farhana. Nice case.
Farhana. Professor
Nice
Afzalur.
case.
Thank you,
Keep it up.
sir.
Keep it up.
Thank you, sir.